Hello, my friends. It's Dr. Sharon with Clinic Reviews. Today we are returning to the Blue Book. You can see the Blue Book right over there over my shoulder. That is published by Mark Klimek. You can find it at Amazon, and it is fundamental knowledge that you have to have. And so what Mark does is he puts in the book content that you need to know, and then I write questions to go along with the book, and I test your knowledge based on if you studied the Blue Book. So let's go ahead and get started. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews, the home of the very best Nclex review in the entire universe. In my opinion, you know that Mark Klimek is the GOAT of Nclex Review, and this channel is a part of the greater Clinic Review organization. You can go to our website, clinicreviews.com, and get our 21 plus hour Nclex prep course online on demand. You can also sign up for our streaming service where you can find all of the videos that are here on YouTube, as well as some that have been deleted and some extras that I've put on there. You can also sign up for our 4-time small group tutoring. It's once a week for 4 weeks. If you want to meet me live over Zoom, you can sign up for that. So I was just talking to Mark the other night, and I said, how does the Blue Book sell on Amazon? Because I don't make any money off of it. So I said, how does that sell on Amazon? He said, well, right now it's number 2 on Amazon for Nclex RN preparation. There's some other test prep books that are ahead of his, but they're more getting ready for a CCRN or Advanced Practice RN, APRN stuff. So he said he's number 2 on Amazon. So thank you so much for making his book number 2 on Amazon. I don't make any money off of that, but I appreciate it because Mark has been very good to me. He's a wonderful person. He's an amazing guy, and I appreciate you doing that. So we're going to do myocardial infarction. Myocardial infarction, it's a part of physiologic adaptation, all right? Now, some of these questions are pretty fundamental, but y'all, you have to know your fundamentals or you cannot pass Nclex. I'll say it again, you have to know your fundamentals or you cannot pass Nclex. I'm going to ask some harder questions at the end, take it up a little bit of a notch, but these are fundamental questions that you have to know. A 62-year-old man with a history of hypertension and smoking presents with crushing chest pain and diaphoresis. Which of the following is the most significant modifiable risk factor for his MI? Age, male gender, smoking, family history of coronary artery disease. Yes, I know it's super fundamental, but you have to know the difference between modifiable and non-modifiable risk factors. So which of these can be changed? That means modifiable. Which of these can be changed? He can stop smoking. That's the modifiable one. A patient arrives in the ED 90 minutes after onset of chest pain. Which intervention has the highest priority to limit myocardial damage? Administer high-dose statin, give sublingual nitroglycerin, initiate percutaneous coronary intervention, or start IV beta blocker. So you have to know how to read these questions. This is fundamental. You have to know testing. You have to be testing competent, Nclex test competence. You have to know how to read the questions. And one of the main things is you only know what you know. You cannot read into this, and you have to answer the questions that's being asked. So he arrives 90 minutes after onset of chest pain. Which intervention has the highest priority to do what? Limit myocardial damage. Limit myocardial damage. So in other words, what can we do? There's already been some damage, right? Because he's been having crushing chest pain, or I guess chest pain. He's been having chest pain for 90 minutes. So assuming that it's an MI, how can we limit the damage? High-dose statin? No. Sublingual nitro? Maybe. Initiate PCI, percutaneous coronary intervention? Maybe. Start an IV beta blocker? No. Starting an IV beta blocker can help, but it's not going to be the highest priority for limiting myocardial damage. What's the best way, just theoretically, what's the best way to limit myocardial damage? Reestablish blood flow. Would you agree with me? Because a myocardial infarction is lack of blood flow. You have a greater oxygen demand than you have supply. So your supply is limited. Okay, so you increase supply. So beta blockers reduce demand, but they don't increase supply. A statin doesn't do either one of those things. Sublingual nitro can decrease demand and increase supply a little bit, but it mostly decreases demand. Percutaneous coronary intervention is the only one that increases supply because you go in and open up the artery. So don't say to yourself, well, but I don't know if he's eligible to have a PCI. I mean, is he someone that's could he even do it? I don't know. We need to know more about him. No, you don't. Because it's a fundamental question. It's just saying, do you know which one of these things will reestablish blood flow? Because the best way to limit myocardial damage is to reestablish blood flow. And the only one out of all these things that does that is the PCI. Which laboratory finding confirms myocardial necrosis in the setting of an MI? Troponin I elevation at 6 hours post-onset, CKMB elevation returning to normal by 24 hours, myoglobin elevation lasting 48 hours, elevated BNP. So you have to know what the word myocardial necrosis means. Did you know the word infarction means tissue death? Infarction means tissue death. So myocardial ischemia is a lack of oxygen, but no death yet, right? So ischemia is lack of oxygen. But if you end up with an infarction, that means tissue death. So this is a bit of a redundant question. Which one confirms that there actually has been tissue death? Necrosis is tissue death. It's the same thing in the setting of an MI. So which one confirms that there actually been tissue death? So the CKMB is going to stay elevated a lot longer. If it only elevates for a little while, that's not significant. Myoglobin, I don't know what the times are for myoglobin, but that's not a significant finding as it relates to necrosis. Elevated BNP has to do with the stretching of the ventricle, has nothing to do with tissue death. The only one that's consistent with tissue death here is the troponin I, and it's elevated at 6 hours post-onset. So the troponin I elevates quickly, and what it does, troponin is released from cardiac cells when they die. That's what the troponin I is. It's released from cardiac cells when they die. That's why we measure troponin I to determine if they've had a myocardial infarction. A patient post-MI develops a new loud, harsh, holosystolic murmur at the apex with radiation to the axilla. Which complication should the nurse suspect? Ventricular septal rupture, papillary muscle rupture, free wall rupture, pericarditis. Yikes, that's a lot of rupturing. All right, now here's a testing strategy. If you don't know what some of these words are, either turn them into words that you know or ignore them. Okay, so post-MI develops a new, I know what that word means, loud, okay, harsh, okay, holosystolic. You might go, I don't know what that means. Holosystolic. All right, so you don't know what it means. Murmur. I know what that means. A murmur is that sound that the heart makes when the valves are not closing all the way. Because when they're not closing all the way, what happens is they close. Normally they close and it stops blood flow. So that lub-dub, that noise, right? That noise is a result of the valve closing and stopping blood flow. It's a sudden stopping of blood flow. That's how you get that noise. So what happens if after they close, they don't close all the way, and so some of the blood regurgitates back through the valve? That's a swishing sound. That's a murmur. That's what a murmur is. Okay? A murmur is an incomplete valve that allows blood to regurgitate back through it. So I say, if I hear a murmur, what do I know here? Because I'm going to answer the question based on what I know and not what I don't know, right? We answer questions based on our knowledge, not our ignorance. So I say, I know a murmur has to do with incomplete closing of the valve. Is there anything here that has to do with the valves? Ventricular septal rupture, that has nothing to do with the valves. Papillary muscle rupture. Well, the papillary muscles are what hold the valves in place. They contract and relax, and they open and close valves. That's what the papillary muscles are. Do you remember your anatomy class? Okay. You never thought you'd have to remember that, right? So they contract and relax and they open up the valves. Okay, so maybe B, free wall rupture. That has nothing to do with the valves. Pericarditis has nothing to do with the valves. The only one here that has anything to do with the valves is B. So I am not going to teach you what a harsh holosystolic murmur at the apex with radiation to the axilla is. You don't need to know what it is. You hear me? You don't need to know what it is because you can't know everything. You cannot know everything. So what you do is you go, well, I know what a murmur is. I know it has to do with the valve, so I'm going to pick the answer that has something to do with a messed up valve. Okay? 48-year-old woman recovering from an infarction is receiving metoprolol, which is a beta blocker. You have to know what your all drugs are, beta blocker. Her heart rate is 52 and blood pressure is 100/60. What is the nurse's best action? Give the dose, administer half the dose, encourage the patient to exercise to raise heart rate, hold the dose, and notify the provider. So I'm not going to do B for sure. I'm not going to administer half the dose. That's outside my scope of practice unless I have an order for that. And I'm not going to encourage them to exercise to raise heart rate. I mean, I might, but this is a best action question. What's your best action? So I'm not going to do that. Like that's not what we normally do. Okay. So the question is, do I give it or do I hold it and call the provider? And if you're going to hold it, you do have to call the provider because you can't hold it without an order for it, right? So holding it, calling the provider is the correct is what you would do. Or you're going to give it. Which one? Give it or hold it. So the question is, what do beta blockers do? They reduce sympathetic nervous system stimulation of the heart, which means they slow heart rate. Primarily is what they do. They primarily slow heart rate, and as a result, they may or may not lower blood pressure. They don't always lower blood pressure. And we don't have a dose there, so I don't really know what it's going to do to blood pressure. Like the higher the dose, the more likely it is to affect blood pressure. So is a heart rate of 52 okay? No, it's under 60. Do I give a beta blocker when the heart rate is low when I know it slows heart rate? That seems like not a good idea to me. Is the blood pressure okay? Honestly, the blood pressure is okay. If it was systolic was under 100, I would probably hold it and call the provider, but I'm okay with the blood pressure. But the heart rate is too low, so I'm going to have to hold it and notify the provider, and you do have to know beta blockers. Which symptom in an older adult MI patient may delay diagnosis due to atypical presentation? Crushing substernal pain, left arm pain, epigastric discomfort and dyspnea, or diaphoresis. So you have to know how to read this question. They are not asking you which of these symptoms causes a delay. So you don't have to say, well, if they have crushing chest pain, there may be a delay. What they're asking you really is which of these is atypical presentation. So which of these might an older adult have? And because it's atypical, they don't even think to go to the hospital. They go, oh man, I'm having this problem, but I don't know, maybe I'll just sit here and wait. Man, I need an antacid, right? So instead of going to the hospital going, oh, I think I'm having a heart attack, they like wait around. So what it's saying is which symptom is atypical and may result in a delay of the diagnosis in an older adult. So is crushing substernal chest pain atypical? No. Left arm pain? Atypical? No. Epigastric discomfort and dyspnea? Yes. Diaphoresis? No, that's not atypical. So the A, B, and D are all typical symptoms, whereas C is atypical. And if that's the only symptom, those are the only symptoms they have, it may delay diagnosis because they may not go to the hospital. A patient on thrombolytic therapy for STEMI, ST elevation MI, myocardial infarction, suddenly becomes hypotensive with distended neck veins and muffled heart sounds. Which immediate action should the nurse take? Prepare for emergent pericardiocentesis, increase IV fluid rate, auscultate lung sounds, administer another bolus of thrombolytic. So the question is, do I have enough information here to take action? Because remember, part of physiologic adaptation is identifying complications and knowing what to do about them, okay? So this is a complication of thrombolytic therapy. Hypotensive, that tells me they're either that tells me they're probably hypovolemic. It could be cardiogenic. It could be cardiogenic or hypovolemic, but one of them, they're having a volume issue or heart failure with distended neck veins. Okay, so that makes me think heart failure, but muffled heart sounds. So muffled heart sounds tells me the the backing up of the blood that's causing the distended neck veins may be because the pericardial sac is filled with fluid. So maybe they've had this thrombolytic therapy, and maybe that sac around the heart, the pericardial sac around the heart, may be filled with fluid, which is constricting contraction, decreases cardiac output, and ends up backing up to the neck veins and decrease cardiac output, so their blood pressure drops. So one of the key things here is this muffled heart sound, so don't ignore that. So do we have enough information to say, I think I know what the problem is? I think the pericardial sac is full of fluid and not letting the heart beat. If that's the case, if I say, well, I have enough information to do that, then I can say what to do about it. And preparing for emergent pericardiocentesis, which is sticking a needle in the pericardial sac and pulling the fluid out, would be the appropriate intervention. So A looks like a good option. My dog is down here, so that's why I look sort of weird. Increase IV fluid rate. Maybe that treats the hypotension, but it doesn't address the distended neck veins and muffled heart sounds. Auscultate lung fields. Well, I have enough information. I don't really feel like I need to do any more assessment. Administer another bolus of thrombolytic. That does not address any of the problems. The only one that addresses all three of the problems is A, prepare for emergent pericardiocentesis. And I have enough information. I don't need to do any further assessment because it's pretty clear what's going on. A patient post-MI echocardiogram shows an ejection fraction of 35%. Which statement by the patient indicates correct understanding of the prognosis. So the question is, well, what's the prognosis? So ejection fraction is the percentage of blood ejected with each contraction of the heart. And at rest, normal ejection fraction is 60 to 65%. So their ejection fraction, which is the percentage of blood ejected with each contraction of the heart, is half of what it's supposed to be, a little more than half. So let's say you have 100 mils in the heart after, 100 mils in the left ventricle after it fills. And you have a 65% ejection fraction. That means 65 mils is ejected at rest. Now, the reason it's not 100% is because if you get up and decide to run out to the mailbox to get your mail, you're going to need a little more blood. And so ejection fraction goes up, okay? Increased forced contraction with the sympathetic nervous system and all that. So if your ejection fraction at rest is 35%, it can go up with exercise, but it's not going to go up to where it normally is. So you've only got about half of the cardiac output that you normally have, right? So what is that? Well, that's heart failure, which is a common complication after an MI. So what is the understanding of the prognosis? Okay, so the prognosis is heart failure, even though it doesn't say that. Well, that's the diagnosis. The prognosis is what happens when they have heart failure. Like, what's the implication of that? My heart is pumping normally? Well, no. This EF means I'm at low risk for heart failure? Well, no, it means they have heart failure. EF has no impact on my medications. That's not right. I have reduced pumping ability and may need an ACE inhibitor. Well, yeah, they definitely have reduced pumping ability, and the ACE inhibitor, angiotensin converting enzyme inhibitor, has been found to help survivability of those with heart failure. So that's appropriate. Now, I was looking for something a little different. Maybe I was looking for something that said, I may not live as long because I have heart failure, or my heart is only pumping out half of what it's supposed to be. Like, I may have been looking for that answer. I didn't see it. So that means I have to pick the answer that's most consistent with what I know is going on. Which finding 1 week after MI requires immediate intervention? S3 gallop on auscultation, crackles at the lung bases, 1+ peripheral edema, or new onset of 2-to-1 AV block on telemetry. So this is a good question because immediate intervention is something that's unexpected. But this question is a little different. So when I get a question like this and I go, well, S3 gallop, crackles, and edema are all symptoms of heart failure. So is heart failure expected 1 week after MI? Not severe heart failure, but mild heart failure. I don't know that it's expected, but they are all the symptoms of the same problem, and they all indicate mild heart failure. Whereas D is a 2-to-1 block. That means for every 2 P waves, it takes 2 P waves to get a QRS. So 2 P waves for every QRS, which means half of the time that the impulse is not going through the AV node. That's pretty significant. Every other beat is not going through the AV node. So we've got now like a 2nd-degree heart block. That's pretty significant. So which one requires intervention? Mild heart failure or a 2nd-degree heart block? And I say, well, I have 3 symptoms that all indicate the same problem and one that's different. So I'm going to go with the one that's different. Because how would I pick between A, B, and C? They all essentially mean the same thing. They all mean the same thing. They all indicate heart failure. How am I going to pick between them? I really can't. So I'm going to pick the one that I know is a problem and it's different from the others. A patient fires post-thrombolytic therapy for an acute MI develops sudden hypotension, jugular venous distension, and muffled heart sounds. Which complications should the nurse suspect? Well, Sharon, didn't we just get this question? I want to show you how similar content can be asked different ways, and this is why you have to be prepared to answer questions conceptually. Don't just memorize one answer. You have to be able to understand conceptually what's going on. So I say, well, post-thrombolytic therapy, hypotension, jugular venous distension, and muffled heart sounds. So I go, well, that sounds like pericardial, like fluid in the pericardium. All right, so papillary muscle rupture. Well, that's not fluid in the pericardium. Ventricular wall free rupture leading to tamponade. So I say, well, I don't know what a ventricular wall free rupture is, but I know a tamponade is fluid in the pericardial sac. That's what it is. Left ventricular aneurysm. That is not fluid in the pericardial sac. Right ventricular infarction. That's a myocardial infarction. That is not fluid in the pericardial sac. So the only one that makes any sense here is the one that uses the word that I'm most familiar with, which is tamponade. Now, I'm not here to teach you what a ventricular wall free rupture is because it doesn't matter that you know it for the Nclex. Look, I'm not telling you as a clinician that you don't need to know it. If you're going to be like a cardiac ICU nurse, then you need to know it. But you need to pass your Nclex first, okay? And you got to pass your Nclex, and you don't have to know everything there is to know. Before you pass your Nclex, you have to be able to use common sense and clinical reasoning to answer some of these questions. So that's what I'm teaching you how to do. A 58-year-old man presents with crushing chest pain radiating to his left arm and jaw. That doesn't sound good. Diaphoresis and nausea. Oh, dear. Sounds like an MI to me. Which diagnostic test result most confirms an acute myocardial infarction? Troponin I elevated at 0.02. CKMB normal at 2% of total CK. ST segment elevation in leads 2, 3, and AVF. T wave inversion in leads V1 through V3 on the ECG. So I say, well, if the CKMB is normal, I can't imagine that that's going to tell me they're having an MI. So I'm crossing that one off. And I don't know that T wave inversion, it's not common to me, common knowledge, the T wave inversion indicates MI. I mean, maybe in some situations it could, but like that's not common knowledge, right? So I'm going to cross off B and D. So I say, is it troponin I elevated at 0.02? So you do have to have some understanding of what elevation is. And 0.02 is within normal limits. And even if your lab, like some labs are slightly different. So even if your lab says, well, it's supposed to be less than 0.01, 0.02 is not high enough to say they're having an MI. Okay, y'all, it's just not. So I may say, I don't know what ST segment elevation. I don't know what the significance in 2, 3, and AVF. Oh my word, I don't know. Does that matter? So what do you do when you don't know? You say, well, I'm going to ignore that part of the answer. And I'm going to say, does an ST segment elevation confirm an acute MI? Remember, we saw that abbreviation, STEMI, STEMI. Do you know ST elevation is an indication of an MI? So out of all these, the only one that I know for sure is an indication of an MI because troponin I at 2.02 seems normal. CKMB says it's normal. T-wave inversion isn't something I'm that familiar with as it relates to MI. So, but I know because a STEMI is an MI and I know ST segment elevation is an MI. So I'm picking the one I know. I'm going to answer this based on my knowledge and not my ignorance. Which medication should the nurse administer first to a patient on arrival with chest pain presumed to be MI. It doesn't say best, it says first. And it doesn't even say what your purpose is. It doesn't say to prevent progression of the MI. It doesn't even say that. It just say, what do you do first? High dose statin, morphine sulfate, aspirin, 325, or nitroglycerin. So I'm crossing off A and B. So to me, if it were me, if I were you, I would be between aspirin and nitro. And if you don't know this, aspirin is always first. If your dad or your mom or you were to call 911 and say, I'm having chest pain, they say, we're sending the squad, take an aspirin, chew an aspirin while you're waiting. Okay. And if you haven't, that's what they're going to do first thing in the squad. And if the squad hasn't done it, that's what they're going to do first thing in the ED. All right. So that is the first thing that you do. All righty. Well, that was maybe not as complicated as some of the other videos that I've done, but it focuses a lot on fundamentals. It focuses a lot on testing strategy. So I taught you that you test or you answer questions based on your knowledge and not your ignorance. I said if 3 answers essentially mean the same thing, none of them can be right. You're going to go with the one that's not like the others as long as it's abnormal, right? So there are a number of testing strategies I taught you in this video. So don't just like go, that was easy. This wasn't about the difficulty level of the questions. It was about testing strategies and some fundamental knowledge. So I hope that was helpful to you. I'll see you next time.